Good morning or good afternoon, depending on the time zone. Thank you very much for the invitation. It's a great honor for me. Here are greetings from Krakow. Disclosure. I will ask to present the case report, but due to the many aspects of the method, I decided to refer a bit more broadly. Currently, the stages of treatment are clearly outlined: intravascular without stent implantation, then bypass, and finally amputation. There is a constant progress in the treatment of atherosclerotic lesions of the arteries, with a constant trend towards less and less invasive. Although in some areas, open surgical treatment is still the gold standard, we try to use new, minimally invasive technologies as much as possible. Intravascular lithotripsy, IVL, is such a method with particular indication for areas that are difficult to treat. It means arteries narrowed with highly calcified atherosclerotic plaques. Considering this new technology, means shockwave IVL, we should pay attention to the histological aspects of atherosclerotic lesions. As we can see in the diagram, changes that are currently the most difficult to treat are changes strongly saturated with calcium within the medial layer and intimal as well. And other, also extremely difficult to treat, are changes like coral reed protruding into the arterial lumen. Difficulty in treating severe lesions in balloon angioplasty without and with stent are connected with frequent peri-procedural complications and more frequent target lesion revascularization. In turn, high-pressure non-compliant balloon angioplasty may be of insufficient force to modify the entire calcified lesion. Scoring and cutting balloons after fail to reach the calcified target lesion. Rotational and orbital atherectomy targets superficially calcified plaque only. The effect of lithotripsy is based on cavitacy phenomenon, in which the static pressure of the liquid reduces to below the liquid's vapor pressure, leading to the formation of small vapor-filled cavities in the liquid. When subjected to higher pressure, these cavities, called bubbles, collapse and can generate shock waves that may damage structure of the calcified solid tissue. These shock waves are strong when they are very close to the imploded bubble, but rapidly weaken as they propagate away from the implosion. First, the method was used to crush kidney stones. In the 2070s, IVL obtained the CE mark for use in coronary and then peripheral arteries. The IVL system consists of a portable and rechargeable generator, connector cable with simple magnetic connections, and push button for activation, disposable IVL catheter. The operation of the IVL system is very simple. The correct diameter of the catheters should be selected in advance. An IVL catheter should be inserted into the narrowed vessel based on the standard endovascular techniques. When properly positioned, a balloon is expanded to 4 atmospheres pressure for a good apposition. Then emitters are activated and electrical discharges generate sonic waves, which rapidly expanding, then collapsing generates sonic pressure waves. These waves crack calcium deposits in media and intima with an effective pressure 50, sometimes 80 atmospheres. Finally, cracked plaques might be dilated by the integrated with the IVL catheter balloon. The most important information at this slide was showing the appearance of the IVL probe and its dimensions. It means length 60 millimeters and diameters increasing by 0.5 millimeters from 3.5 millimeters to 7 millimeters. And now 5 cases to be shown. The first one, male, 76 years old, diabetes, hypertension, coronary artery disease with heavy calcified two-level critical stenosis of distal SFA and popliteal with almost complete occlusion of distal SFA with very well extended collaterals. We used 5 millimeters IVL catheter, ABI before 0.68, after 0.97, and extending of distance of claudication from 50 meters to 400 meters. No complications, no dissection, no distal embolization. The next one is case number 2, male 85 years old, diabetes, hypertension, coronary artery disease, myocardial infarction 2020, heavy calcification with the almost complete occlusion of distal SFA with very well extended collaterals. We used 5 millimeters IVL catheter, ABI before 0.62, after IVL 0.99, extending the distance of claudication from 30 meters to 400 meters. No complications, no dissections. Third one, it's women 84 years old with diabetes, coronary artery disease, renal insufficiency, heavy calcified multi-level critical stenosis of distal SFA, popliteal and trunk, with the only anterior tibial anterior competent. We used 4 millimeters IVL catheter, ABI before IVL 0.53 and after 0.84, extending of distance of claudications from 5 meters to 150 meters. No complications, no dissections, no embolization, about 20% residual stenosis. Fourth case, male is 69 years old, coronary artery disease, hypertension, heavily calcified coral leaf plaque occluded distal popliteal on the level of division to anterior tibial and trunk with quite well extended collaterals. 4 millimeters IVL catheter was used. We got extending the distance of claudication from 50 meters to 300 meters. No complications, but about 70% residual stenosis of ATA left, but we can't open it in this procedure. And the last one case, male 72 years old, diabetes, hypertension, in 2018 PTA writes SFA in proximal part, 19 PTA SFA in distal part, with very calcified plaque, with significant stenosis of common femoral artery, proximal and distal, instead stenosis of SFA, no deep femoral arteries. 5 millimeters IVL catheters was used, and we got the extension of distance of claudication from 40 to 250 meters. No complications, no dissections, but about 20% residual stenosis of distal common femoral and proximal superficial femoral instant. Referring to the most advanced study in this field, the Disrupt PAD study, authors found an unusually low percentage of major adverse events, only 1.1% of perforations and dissections, a low percentage of residual stenosis, and high percentage of patency and freedom from TLR. And from the same study, comparison of the clinical effects of AF for IVL and PTA, as you see. And the unique case of this application is that IVL might be used in no-stent zone, means in second and third popliteal, inguinal, and iliac bifurcation. In the high-risk situation, for example, bifurcation, single vessel runoff, subintimal use, and failed PTL. In non-surgical candidates, means very poor state, facilitating safe transfemoral access for large bore devices such as TAVI and EVER or EVER. It's very interesting. And till now, off-label, instant restenosis. Finally, shockwave intravascular lithotripsy system may minimize trauma, optimize outcome, simplify the treatment of challenging calcified arteries. Thank you very much.